Welcome to this deep dive into heart failure, where we will understand the silent struggle of this chronic condition from the inside out. Imagine your heart, the relentless organ that has been beating for you every single second since before you were even born. Heart failure is a silent decline. It doesn't happen suddenly like a heart attack, but slowly, quietly, and painfully. Day by day, the heart becomes weaker and weaker. Heart failure does not mean the heart has stopped working. Instead, the heart muscle is too weak or stiff to pump blood effectively. Recognizing this progressive decline is the first step in saving a patient's quality of life. Heart failure is a global epidemic, with over 64 million people living with this diagnosis worldwide. These patients need excellent, knowledgeable nursing care to manage their complex symptoms and medications. I'm your student guide from Body Bites. My mission is to help you understand the human body. Today, we're diving deep into one of the most vital topics in nursing to build your clinical expertise. Our agenda today includes decoding the pathophysiology, recognizing the symptoms, and mastering the nursing management of the failing heart. First, we'll cover core physiology, defining cardiac output, and how a healthy heart functions. Then, we'll examine the causes of failure, such as hypertension and myocardial infarction, that stiffen the heart muscle. We will trace the clinical progression, starting with the body's compensation attempts, moving to the visible symptoms like edema, and finally, connecting the physiological dots to understand the why behind the symptoms and effective nursing management. This video is the path to excellence. We are moving beyond simple theory to a deep understanding, connecting the dots between pathophysiology, compensation, and the patient in the bed. This is what transforms you into an excellent, life-saving nurse. Prepare to learn and grab your notebook. This video is absolutely packed with critical information. Eliminate distractions, focus your mind, and get ready for a transformative learning experience. Let's dive in. Are you ready to deeply understand heart failure? Welcome to this video on understanding cardiac output, a concept essential for diagnosing and treating heart failure. Cardiac output is defined by the equation of life. Cardiac output equals heart rate multiplied by stroke volume. It represents the fundamental mechanism of blood circulation. In a healthy adult, the heart rate is around 70 beats per minute, and the stroke volume is about 70 milliliters per beat. This results in a cardiac output of roughly 5 liters per minute, meaning your entire blood volume is pumped every minute. Stroke volume is the exact amount of blood pumped out with each beat. Understanding this metric is crucial for understanding heart failure. It is governed by 3 critical physiological components, or 3 pillars. The 3 pillars of stroke volume are preload, afterload, and contractility. Preload is the blood volume filling the ventricle before contraction. Afterload is the resistance the heart pumps against. Contractility is the heart muscle's inherent strength. Preload relates to the Frank-Starling Law. Like stretching a rubber band, the more the heart muscle is stretched by blood, the stronger the subsequent contraction will be, resulting in more blood ejection. Afterload is the resistance the heart must overcome. Using the straw analogy, high afterload, often due to high blood pressure, forces the heart to work harder. Over time, this leads to muscle fatigue and weakening. Contractility is the heart muscle's vitality. In heart failure, one or more of these factors, preload, afterload, or contractility, fail. When cardiac output drops, the systemic collapse affects every organ in the body. Welcome to this video on the body's compensations, an awe-inspiring look at how the human body fights back against heart failure. We must appreciate the remarkable nature of physiology. When the heart begins to fail, the body does not give up. It fights back with everything it has to keep you alive. The first compensation is tachycardia, a rapid heart rate. When stroke volume falls, the sympathetic nervous system releases adrenaline to increase the heart rate. However, a faster heart demands more oxygen and reduces filling time, causing stroke volume to drop further. Compensation 2 is the Frank-Starling mechanism, or the rubber band effect. The body retains fluid to stretch the cardiac muscle fibers, initially resulting in a stronger contraction. The flaw is that beyond a critical point, the overstretched heart muscle contracts less efficiently. Compensation 3 is ventricular hypertrophy, which can be concentric or eccentric. Concentric hypertrophy thickens the walls due to high afterload, making the heart stiffer. Eccentric hypertrophy dilates the chambers due to volume overload, causing them to lose their efficient oval shape and contract less effectively. Compensation 4 is RAAS activation. The kidneys activate the renin-angiotensin-aldosterone system to maintain blood flow, commanding the kidneys to retain sodium and water. The dangerous flaw here is the resulting fluid overload, leading to pulmonary and peripheral edema. Compensation 5 is vasoconstriction, or diverting the flow. The body diverts blood from non-essential areas to protect the heart, brain, and kidneys. However, widespread constriction sharply increases afterload, forcing the weakened heart to work even harder. Ultimately, the tragedy of heart failure is that all these desperate survival mechanisms eventually worsen the heart failure. This creates a vicious cycle that, without medical intervention, leads to progressive deterioration. The vicious cycle involves fluid retention causing stress, tachycardia increasing oxygen demand and damage, and vasoconstriction creating high afterload. These three elements continuously compound the strain on the failing heart. Welcome to this deep dive into the pathophysiology of heart failure. We will explore the cellular and systemic mechanisms driving cardiac decline. We're going deep into what is happening inside the body when the heart begins to fail. This is where clinical pathophysiology reveals its complexity. The first step is a drop in cardiac output. The heart weakens, unable to pump an adequate volume of blood. Normal output is about 5 liters per minute, but in severe heart failure, this can plummet to 2 liters per minute, depriving major organs of oxygen. With reduced cardiac output, systemic perfusion pressure drops. The kidneys are highly sensitive to these blood flow fluctuations. They interpret the low flow as severe dehydration, activating the powerful renin-angiotensin-aldosterone system, or RAAS, to protect blood pressure. The RAAS cascade begins with renin release from the kidneys, converting angiotensinogen to angiotensin-1. Next, the angiotensin-converting enzyme, or ACE, in the lungs transforms it into angiotensin-2, which then stimulates the adrenal glands to release aldosterone, causing fluid retention. Angiotensin-2 has a dual impact. It causes vasoconstriction, squeezing blood vessels to raise blood pressure, and stimulates aldosterone release, leading to significant sodium and water retention, expanding total blood volume in a desperate attempt to fix the failing pump. The body also activates the sympathetic nervous system. This causes tachycardia, accelerating the heart rate. Contractility increases, demanding more oxygen. Diverted flow shunts blood away from the extremities to prioritize the heart, brain, and kidneys. Next, fluid overload begins. While fluid retention initially boosts the heart's pumping via the Frank-Starling Law, excess fluid overloads the heart. The chambers stretch excessively, further weakening the muscle, pushing past the physiological limit. The fluid backup manifests differently in left versus right heart failure. Left heart failure leads to fluid leakage into the lung air sacs, causing pulmonary edema and severe breathlessness. Right heart failure results in leakage into dependent tissues, causing pitting edema, ascites, and hepatomegaly. The final stage is cardiac remodeling. This involves hypertrophy, where muscle cells grow larger to fight resistance, and chamber dilation, where the heart loses its efficient shape, severely reducing ejection fraction. Fibrosis replaces healthy muscle with rigid scar tissue, and leaky valves cause blood to flow backward. Every compensatory mechanism, from RAAS fluid retention to sympathetic adrenal insertions, forces the heart to work harder. This ultimately creates a vicious cycle, making the already failing muscle progressively weaker over time. Welcome to this video on understanding heart failure, where we will demystify the mechanics, types, and progression of cardiac decline. A critical misconception is that heart failure means the heart has stopped. The heart is still beating, but it cannot pump enough blood to meet the body's demands. There are two main types of heart failure. Type 1, HFrEF, is systolic heart failure, where the heart muscle becomes weak and cannot contract properly. Type 2, HFpERF, is diastolic heart failure, where the heart muscle becomes stiff and cannot relax to fill properly. In left heart failure, the left ventricle fails, causing blood to back up into the lungs. This leads to pulmonary edema, resulting in symptoms like severe breathlessness, persistent cough, and difficulty lying flat. Right heart failure occurs when the right ventricle fails, causing blood to back up into the systemic circulation, the rest of the body. Symptoms include swollen legs, swollen abdomen, and liver enlargement. This table summarizes the comparative symptomology. Left heart failure primarily affects the lungs, causing pulmonary edema and respiratory symptoms. Right heart failure primarily affects the body, leading to systemic edema and swelling. Congestive heart failure, or CHF, occurs when both sides of the heart fail. It's the most severe form of heart failure and requires immediate, aggressive medical management. Welcome to Part 5, Symptoms Explained, where we focus on the physiology first. We will connect every clinical manifestation of heart failure to its underlying physiological mechanism. Our clinical approach emphasizes understanding symptoms, not just memorizing them. This physiological focus is key to grasping heart failure's clinical picture. Dyspnea and orthopnea often stem from left heart failure. Blood backing up into the pulmonary veins increases hydrostatic pressure, causing fluid to leak into the alveoli and impairing gas exchange. Orthopnea worsens when lying flat due to fluid redistribution, leading patients to sleep elevated to reduce these shifts. Paroxysmal Nocturnal Dyspnea involves patients suddenly waking up, gasping for breath, typically 2 to 3 hours after falling asleep. This occurs because fluid from the legs redistributes to the chest while lying flat, overwhelming the pulmonary system. Patients sit upright for relief. Pitting edema is localized swelling due to increased venous pressure, forcing fluid out of capillaries into interstitial tissue in right heart failure. Fatigue and weakness are caused by reduced cardiac output, meaning less oxygen and vital nutrients reach skeletal muscles for energy. Pink frothy sputum signifies advanced pulmonary edema. Fluid accumulates in the alveoli, mixing with air to create frothy sputum. High capillary pressure causes microhemorrhages, tinging the fluid pink. This is a medical emergency. Act immediately. Reduced urine output, or oliguria, results from decreased cardiac output, reducing blood flow to the kidneys. In response, kidneys conserve water and sodium, causing urine output to drop. This compensatory water retention dangerously exacerbates fluid overload. Altered mental status is due to reduced perfusion, meaning less blood reaches the brain. This causes cerebral hypoxia, denying brain cells the necessary oxygen. Neurological deficits like confusion, restlessness, and inability to concentrate manifest quickly. Welcome to Part 6, focusing on heart failure management. We will cover comprehensive nursing care and pharmacological treatment strategies. Our management approach has 5 core objectives: improving cardiac output and tissue perfusion, reducing fluid overload, relieving symptoms, slowing disease progression, and preventing acute complications. Pharmacological intervention in heart failure revolves around the big 4 medications, which are the foundational pillars of treatment. For volume and afterload reduction, we use diuretics like furosemide to eliminate excess fluid. We also use ACE inhibitors, such as ramipril, which block the RAAS pathway, preventing vasoconstriction and reducing afterload. Nurses must monitor fluid output, electrolytes, and blood pressure with diuretics and vital signs with ACE inhibitors. Rate and contractility control involves beta blockers, like carvedilol, to protect the heart, starting at a low dose. Digoxin improves contractility in chronic HF, but has a narrow therapeutic window, requiring careful monitoring for toxicity signs like severe bradycardia. Continuous monitoring and immediate clinical interventions are crucial, forming the critical safety net that stabilizes and protects heart failure patients. Immediate patient care includes proper positioning in semi or high Fowlers to ease breathing. Continuous vital sign monitoring is essential to detect early deterioration, along with strict fluid balance tracking, including daily weight monitoring. Further optimization and restriction involve oxygen therapy to maintain SpO2 above 94%, strictly limiting sodium intake to less than 2 grams per day, and enforcing fluid restriction. Close electrolyte tracking is also vital due to the risk of arrhythmias from potassium depletion. Emotional support and education are key. This includes explaining medications and lifestyle changes clearly, emphasizing the importance of daily weight monitoring, and ensuring patients know when to seek emergency help. Empathy and reassurance help alleviate fear. We must watch for critical complications such as cardiogenic shock, pulmonary edema, arrhythmias, and renal failure. Early detection and immediate intervention are critical in managing these life-threatening events. Now that we've covered the basics of heart failure, let's bring it all together with a complete deep dive summary. Let's review the core pathophysiology. The cardiac output equation shows CO equals heart rate times stroke volume, depending on preload, afterload, and contractility. The core deficit is the heart's inability to pump enough blood. The 2 primary types are systolic, a weak, dilated heart, and diastolic, a stiff, non-compliant heart. Left heart failure backs fluid up in the lungs, and right heart failure causes systemic fluid and edema. For clinical management, compensatory mechanisms like tachycardia and RAAS activation initially help maintain pressure, but ultimately worsen failure. Symptoms like dyspnea and edema result from altered hemodynamics. Pharmacology involves diuretics for volume, ACE inhibitors for afterload, beta blockers for rate, and digoxin for contractility. Nursing care focuses on positioning, fluid balance, oxygenation, and education. Heart failure reminds us that the human body never gives up. Even when the heart is failing, the body fights back. Our role as nurses is to support this fight with knowledge, skill, and compassion. If this deep dive helped you, please hit the like button and subscribe to Deep Dive into the Body so you never miss our next breakdown. Let me know in the comments what surprised you most in this video. I read and reply to every single comment.